Hi, everybody. I'm Ashwin,
I'm Raj.
And I'm Eddie.
and this is Blood Cancer Talks. This is a podcast exclusively dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Please remember to rate and review Blood Cancer Talks on your preferred podcast platform. We'll continue to bring you the latest advances in hematologic malignancies. Today, we are excited to talk about one of the most exciting developments in acute leukemia treatment, which is menin inhibitors. We are thrilled to have Dr. Eytan Stein, who is the Chief of Leukemia Service at the Memorial Sloan Kettering Cancer Center in New York. He's also the director of the Program for Drug Development in Leukemia, Division of Hematologic Malignancy at MSK. And Dr. Stein has been at the forefront of menin inhibitor development and was a key investigator in the pivotal Augment 101 trial that led to the first FDA approval in this class. Dr. Stein, thank you for joining us. So before we start, maybe can you tell us about yourself and your clinical and research focus?
Sure. I just want to open up by saying thank you so much for inviting me to have this discussion. I want to particularly thank Dr. Kishtagari, who I had the privilege of working with when I believe I was a fellow and before he even went to residency. And that was a wonderful experience, us really training together and growing up together as doctors. As Dr. Kishtagari said, I'm the chief of the leukemia service at Memorial Sloan Kettering Cancer Center. I have a particular interest in targeted therapies for acute myeloid leukemia, and specifically therapies that induce myeloid differentiation rather than act as cytotoxic chemotherapies. That's sort of how I got into the world of menin inhibitors. It built upon some prior work I had done with other differentiation therapies, which are called IDH inhibitors. And that's sort of how I got into this. I lead a large group. I was counting it up, I have 25 leukemia doctors who report up to me. Half of those doctors are in the lab, half of them are in the clinic. Some of them do a little bit of both. And we are really excited about what we're doing here and what we do in collaboration with all of our colleagues across the world to improve the lives and improve the outcomes of patients with acute myeloid leukemia.
Dr. San, let's get started. We'll start with the case and you can walk us through the data and how would you approach this patient. So this is a 25-year-old gentleman, no past medical history, who presented to the hospital with fatigue and easy bruising and dyspnea on exertion. A complete blood count at the time of presentation showed a white count of 76,000 with almost 70% blast in the peripheral blood, along with hemoglobin of 7.3 and a platelet count of 20,000. Given concern for acute leukemia with the peripheral blood blast, which was confirmed by flow cytometry, patient underwent a bone marrow aspiration and biopsy, which showed 60% monoblast with an immunophenotype consistent with positive for CD14, CD33, CD34, and CD64. Other genomic testing showed that fish was positive for rearrangement of KM2A locus at 11q23 in 78% of the cells. And the myeloid NGS panel was negative for FLT3 NPM1, only positive for ASXL1, but it was deemed to be a variant of uncertain significance, which was at present at a variant fraction of 50.4%. He received 7+3 with no response, given persistent blast even on day 14. His white count was still at 40,000 on day 14, despite getting 7+3. Then, given his young age and a resistant disease, he received reinduction with FLAG-IDA based salvage regimen, with unfortunately also no response. We did a bone marrow biopsy at day 30, which showed that presence of 30% blasts in the bone marrow. So this is a patient. We will talk about how this patient is a good candidate for menin inhibitor. So let's start with the biological foundation, but through the lens of the patient. A young patient with a KMT2A rearranged AML who already failed two lines of therapy. So how would you approach a patient like this when you see in clinic?
Yeah, so I think there are a few features of the case that are actually quite characteristics of patients with KMT2A rearranged acute leukemia or acute myeloid leukemia. The first is that many of these patients have a monoblastic disease or malignant monocytes. And that's sort of a common presentation of patient with KMT2A rearrangements, which leads to, maybe not in this patient, but in other patients, those patients probably having a higher incidence of having extramedullary disease at some time in their course of their treatment. And if they have extramedullary disease and by having monoblastic disease with a high white count, they're more at risk of having central nervous system disease and leukemia cells that have migrated into the cerebrospinal fluid. So that's one thing to think about. The other thing to think about is that the patient presented with a very high white count, even in the absence of having those molecular mutations that we typically think about as driving up myeloid proliferation, like FLT3. Again, relatively common in patients with KMT2A rearranged acute myeloid leukemia. So everything kind of fits in how this patient presented. It's not uncommon for patients with KMT2A rearranged disease to have what's called primary induction failure, meaning that the patient has received 2 cycles of intensive chemotherapy and has not achieved a remission. That happens maybe a little bit more often with certain cytogenetic abnormalities that are KMT2A rearranged. The one I'm thinking about, which I think may be the most frequent, is a 611 translocation. Those patients tend to have a poor response to chemotherapy. So this is a young guy, primary induction failure. I think that with primary induction failure, the choices are relatively slim. If you had a chemotherapeutic approach or a investigational approach that might target the biological basis of this rearrangement, that's something that I would do for the patient. I think if you didn't have a clinical trial available, I think a lot of people would try azacitidine and venetoclax, although I'm not aware of any good data in this setting, KMT2A rearranged with primary induction failure, saying that that's better than doing something else. I think those are sort of the major options that one would consider.
You bring up a lot of good points. So one thing you mentioned about differences between the KMT2 has multiple partners, and you briefly mentioned about 6 and 11 translocation. Do you always factor that in your decision making? That's one question for you. And the second question is, how do you test for these rearrangements? There are multiple partners. There are about, I think, 100 different partners, and we all struggle in the clinic and how to detect these fusion partners.
Yeah. So just to take the second question first, I think that the way we test for the rearrangements is we do just sort of traditional cytogenetics and FISH testing, and that typically will pick up a rearrangement. It usually picks up the translocation partner, but not always. We also at Memorial Sloan Kettering, I think a lot of places are doing this now, can pick up some of these rearrangements on next generation sequencing. We have an RNA fusion panel that we do as a standard of care for all of our patients that picks up the fusions between, or the molecular or the genes that are fused together as part of the rearrangement. The other thing that we've done on an investigational basis, I think they do this actually routinely now at MD Anderson, is something called optical genomic mapping. That is actually really good at picking up these like cryptic translocations that maybe you see something on FISH, but you don't know what the translocation partner is. And optical genomic mapping is actually quite good at picking that up. With all that about the second question, I don't remember the first. Oh, you're asking about what are the outcomes of patients with different translocations. So the way that the ELN recommendations are currently set out, all KMT2A rearrangements are in the unfavorable or adverse risk group, except for 9/11 translocations, which are in the intermediate risk group. There was some data relatively recently published, I believe, from a German group. Maybe I think the first author or senior author might be Lars Bullinger, who is at the Charité in Berlin, suggesting that maybe the 9/11 patients don't do quite as well as we think they do. And There's actually I think there is an abstract at EHA this year, perhaps showing the same thing. And this is important because I have heard people say that, well, if you have a 9/11 translocation, maybe they shouldn't get an allogeneic stem cell transplant at the time of first remission. I would actually, especially in a 25-year-old, I would definitely transplant that patient, assuming there are no issues and concerns about transplant-related mortality.
Yeah, that's a good point. I think even the data from MD Anderson, which Raj will talk subsequently, um, also showed the same thing, although it's retrospective, but showed the same thing that all KMT2 rearrangements are poor. And they had, I think, 172 patients in that cohort with different rearrangements, and all did poorly. There was no differences between individual rearrangements as well.
Yeah, and just to make an additional point, so the data I was talking about was really from newly diagnosed patients. Once a patient is relapsed and refractory with KMT2A rearrangements, universally their outcomes are terrible.
That's a very good point. So you briefly mentioned about menin inhibitors in this young patient who relapsed after 2 induction treatments. Are there any other rearrangements apart from KMT2A which are sensitive to menin?
Yeah, such a good question. So menin is a protein that seems to be associated, the binding of menin to the KMT2A complex, whether it's rearranged or whether it's actually not rearranged, seems to be important in a variety of different leukemias. So we already talked about the KMT2A rearranged leukemia. In nucleophosmin mutated or NPM1 mutated acute myeloid leukemia, it appears to be that menin it plays an important role. Similarly, other leukemias that are associated with the upregulation of Hox genes, those leukemias seem to be dependent on menin to a greater or lesser extent, and there may be a benefit of blocking the interaction of menin and KMT2A even in those other types of leukemia.
So I know that KMT2A and PM1 is something we are seeing, and there is also rare rearrange of NUP98 as well. Do you think it's just a tip of iceberg using menin inhibitors, or there are more ways we can identify the sensitive patient population? Because
Right. So
I heard from some people that you can probably do a gene expression and look at a cohort of AML patients, and HOXA9 can be upregulated in 50% of the patient population. Do you think
yeah,
all these 50 patients should be included in a clinical trial
yeah.
with
So
menin
absolutely.
inhibitors?
So I do think that's something that needs to be tested. I mean, it works in other molecular settings, even with, I mean, which may or may not be related to Hox gene upregulation, because some of the early trials, especially the Cura Oncology and the Johnson & Johnson trial with bleximenib, they included patients without NPM1 and without KMT2A rearrangements, and there were a handful of patients that responded. You may know that Gus Issa and I put together a trial looking specifically at patients who have Hox gene upregulation. We're not testing as an eligibility criteria to get on the study. We're not testing sort of gene expression profiling, primarily because, because it's a clinical trial, the FDA wants a CLIA or FDA-approved test to get on a trial. So as a surrogate for that, we're using molecular mutations that have been associated with Hox gene upregulation. And then on the back end, what Gus is doing is he's going to be looking at sort of a gene expression profile to look and see whether this actually correlates. So yeah, but the answer is, yeah, it could be the tip of the iceberg. And this could affect a much larger proportion of patients or be helpful to a much larger proportion of patients than just KMT2A rearranged in NPM1.
Sort of bouncing off the last two questions, I want to ask you about KMT2A partial tandem duplication and how they factor in both prognostically and regarding menin inhibitor sensitivity.
Yeah, that's a really good question. So one issue with KMT, so partial tandem duplications, for those people who don't know, are when you have duplication of the gene, but the gene isn't rearranged, right? So the locus at 11q23 gets duplicated, but it's not like it's rearranged or fused with something that's on a different chromosome. So one issue is that most labs have trouble identifying, or traditionally have had trouble identifying KMT2A partial tandem duplications. So that's something that, so the real incidence of PTDs, I think, is not entirely known. The PTD doesn't factor into the ELN criteria right now, because I think it's just a little bit unknown, and it may have to do with what the co-occurring mutations are. I mean, I don't think those patients don't have a favorable prognosis. I think the question is, do they have an intermediate prognosis or an unfavorable prognosis? And is the KMT2A PTD independently prognostic of other mutations? So in terms of whether a menin inhibitor would work there, I am aware of one preclinical study in a cell line, I think, where there may have been some benefit. But all subsequent studies and our clinical experience with the menin inhibitors has suggested that those patients with the PTD are not sensitive to menin inhibition. I don't know the biology well enough to say exactly why. It may be that those just aren't sort of Hox mediated in the same way.
I just wanted to discuss, the data that Ashwin was alluding to regarding the prognostic impact of KMT2A rearrangement. So, as Ashwin was alluding to, in 2021 there was a study from MD Anderson on 172 adult patients with KMT2A rearranged AML, which showed the median overall survival was just about 2.4 months following second salvage, compared to 4.8 months in normal karyotype AML. Looking at the KMT2A outcomes paper, the therapy-related KMT2A rearranged AML had even worse outcome, with a median overall survival of just about 0.7 years versus 1.4 years for de novo disease. So these are often patients who survived a first cancer and subsequently, unfortunately, develop a second aggressive secondary leukemia. So prior to the arrival of menin inhibitors, what would be your approach, the treatment while making treatment decisions for these particularly vulnerable patients?
That's a hard question. Part of the issue with these patients, like sort of Ashwin was getting at with the case, is that sometimes you have patients with relapsed and refractory AML, but they're anemic, they're thrombocytopenic, but you can kind of keep them going for 6 months or something by just transfusing them, giving them prophylactic antibiotics, et cetera, et cetera. The problem with these KMT2A rearranged patients is that, or the problem with their disease, the patients aren't a problem, the disease is a problem. The problem with their disease is that this very proliferative white blood count, right? And then you're starting to give these patients, to control that, a lot of hydroxyurea, which makes them thrombocytopenic, which leads to more neutropenia, which leads to all sorts of other problems. I think, in the pre-menin era, I mean, I don't, from a standard of care perspective, these patients would often get, if they were young and fit enough, some sort of salvage chemotherapy, FLAG-IDA, MEC, I don't know, pick your salvage chemotherapy, CLAG-M, pick your salvage chemotherapy of choice. I think people, once aza-ven came around, would try aza-ven. Whether that worked or not, I don't know. Some KMT2A rearranged patients will have a co-occurring FLT3 mutation, so maybe they would try gilteritinib. I think a lot of these patients went on sort of non-specific clinical trials. We had a clinical trial a number of years ago that we published in Blood. Ashwin probably remembers it. This trial with this drug called a DOT1L inhibitor that inhibited another part of the KMT2A sort of complex. Actually, it was an interesting drug. It actually, if you look at the paper, we had a number of patients where their extramedullary disease went away, although it didn't actually put that many people, or really anyone, into remission. So the answer is there are no good therapies, and those patients would get either some sort of suboptimal salvage therapy or go on a clinical trial. But that's why you see in that MD Anderson experience that the median overall survival is really so low.
So now we're going to talk to you a bit about the Augment 101 study. You were there from the beginning. What moment in the conduct of the trial made you think, hang on a second, this actually is going to work?
I'm going to tell you a slightly different story, and then I'll get to the second story, and then I'll get to your question. So Scott Armstrong, who did a lot of the basic biology of menin inhibitors or menin inhibition, for a brief time, he was at Memorial Sloan Kettering as the head of the, I think we have like an epigenetics center. He was the head of the epigenetics center. And I was a very junior attending, probably like 1 year out of fellowship. And he was kind enough to invite me to this like morning coffee with him, Ross Levine, and Marty Tallman, who was my boss at the time and
Pretty
is still,
high-powered coffee.
yeah, still my mentor. So it was a high-powered coffee. And I obviously was like the young guy in the room who didn't like, I felt like I had a little bit of imposter syndrome sitting there, right? Like, oh my God, I'm with these giants in the field. And he would talk about sort of, menin and menin inhibition. And then he talked about this guy named Jerry McGeehan, who had been working on menin at some small company for a very, very long time and had this inhibitor, and he wanted to come talk to us about it. And then Jerry came to talk to us about it. And at least the preclinical data looked really, really good. And subsequently, actually, Jerry, I think the company got bought by Syndax that Jerry was at. And that's how this sort of all came about. Now, in terms of when I knew this was like a real thing that was actually going to work for people, is that one of the first patients I treated on revumenib was this older woman with really the worst gingival hyperplasia I think I've ever seen. She had a monocytic KMT2A rearranged leukemia. I can't remember exactly what the translocation partner was. And her gums had really essentially completely overgrown her teeth. So she really couldn't eat other than eating, essentially applesauce and the equivalent of baby food. And we started her on study. And I would say within 3 weeks, her gums were just like normal again, like just totally normal. And she could eat and she could, her counts subsequently ended up improving. Um, and she went into a complete remission. I think that's when I knew this was like this was something that had legs. I find this more general comment, we do a lot of clinical trials and you all do a lot of clinical trials, and you get a lot of drugs that, maybe the blasts are going down a little bit and maybe the blood counts are improving. But there are certain drugs, like you give them to people and they just work and it's going to be a home run.
Yes, unfortunately, they don't come out about more often, but when they do, I mean, I think that the bispecific antibodies in lymphoma and myeloma have been like that in a similar way and CAR T, of course. But yeah. There seems to be like it's hard to pick them apart from a piece of paper, but at the end of the day, they're very different groups of drugs for sure. So let's talk a little bit about the Augment 101 data. So the trial enrolled 116 patients. For safety analysis and 97 in the efficacy population. They're very heavily pretreated populations. 44% had 3 or more prior therapies, 63% prior venetoclax, and more than half had prior stem cell transplant. Could you tell us a bit more about the population and what the key efficacy results were in Augment 101?
Yeah, so as you said, the population was a heavily pretreated population. Many of the patients had a prior allogeneic stem cell transplant, so they were kind of like the worst of the worst. And that, I think about almost half of the patients had a prior allo transplant and had relapsed after a prior allo transplant. Those patients typically, it's very difficult to cure those patients. Many of the patients had prior venetoclax, sort of speaking to what I said earlier, that I think doctors, for better or for worse, feel like no one should die before receiving venetoclax. So everyone gets a little sprinkle of venetoclax at some point. The primary outcomes that we looked at were the overall response rate of the study and the rate of complete remission and complete remission with partial hematologic recovery, so-called CRH. Now, the response rates differ slightly based on which data cut you're looking at. So just to be clear, there was some data presented at ASH in 2024. There's data published in the Journal of Clinical Oncology in early 2025. And then there's the data in the FDA label, which is also in 2025, I guess, right? So no, 2024. So, and the numbers are slightly different, but overall, just sort of summarizing, the overall response rate is in the range of 63-64%. The rate of CR plus CRH is around 23%. There's a delta then between the overall response rate and the rate of CR/CRH, which we could talk about at some point. And then the duration of response is on the order of 6 months or so. So that's the duration of the number of patients who go into a CR/CRH, how long they remain in a CR or CRH. So I would say impressive data. It's better if you can get a patient to a stem cell transplant once they get into remission, because the drug isn't necessarily durable for years and years and years. But if you can't, it still offers benefit to that patient because, as we talked about, the median survival without a menin inhibitor is significantly lower.
This might get to your point about there being slightly different cuts of the data, but the overall median duration of response, as you mentioned, was around 6 months. But then in the update analysis, it was 13 months. Could you help us sort of reconcile the delta there, or what you think happened between those two different analysis points?
I'm not sure which data they were looking at with the 13 months. That might actually be just looking at patients who received an allogeneic stem cell transplant. I think that if you group all the patients together, I don't think it's as long as 13 months. That seems a little long to me, but I think of the patients who received a transplant, I think the 13 months might actually be the right number.
That's the 13 patients who received allogeneic stem cell transplant and continue to receive post-transplant maintenance.
Maintenance therapy. Yeah. One thing to say about maintenance therapy with menin inhibitors is that menin is involved. I mean, again, you didn't ask, but I'm going to tell you anyway. So menin is involved in normal hematopoiesis. I don't remember exactly how, but we have had a little bit of trouble giving the FDA-approved doses of revumenib post-transplant, just because it seems to cause some myelosuppression. There's actually a trial going on. I was just speaking with a colleague in England who's doing a maintenance trial where they've dramatically lowered the doses of a different menin inhibitor in order to successfully administer it post-transplant.
All right, so the safety profile, of the menin inhibitors did show significant treatment-related adverse events. Can you give us a lay of the land as to what the adverse event profile looks like? What are the main adverse events you're worried about clinically?
Yeah, so I'm going to talk about adverse events maybe first that are, I think, common across all menin inhibitors, and then maybe some that are specific to revumenib. So across all menin inhibitors, like I said a second ago, menin inhibitors can cause some myelosuppression. So we do see some thrombocytopenia, not dramatic thrombocytopenia, but some thrombocytopenia in patients who are on menin inhibitors, maybe even some neutropenia. And I think that's across the board. A second issue is differentiation syndrome. The differentiation syndrome that you see with menin inhibitors is, I would say, or can be dramatically different than what we are used to with patients who receive ATRA and for APL and patients who receive IDH inhibitors. I don't think that has to do with the drugs. I think that has to do with the patient population and the burden of disease in patients with widespread extramedullary disease. Where I think that those patients who are monocytic and have disease not only in their bone marrow, but a large burden of disease outside of their bone marrow, meaning solid collections in their gums and their myeloid sarcomas, extramedullary disease, I think that's maybe what leads to this really dramatic differentiation syndrome that is sometimes difficult to control with corticosteroids. you're probably aware that with the ziftomenib trial from Cura Oncology, early on in the trial, the FDA put them on a clinical hold because there was a death due to differentiation syndrome on that trial. I'm aware of on a different menin inhibitor trial, there was a death or two due to differentiation syndrome. So one of the things we're working on here at Sloan Kettering, I'm working with a talented fellow named Dr. Kai Chen, is trying to figure out the predictors of differentiation syndrome and severe differentiation syndrome in patients who receive menin inhibitors. We have some ideas, not ready for prime time quite yet. And then sort of understanding the spectrum of differentiation syndrome in patients who receive menin inhibitors. And practically, I think the question is, should all patients be, or should some certain high-risk patients be receiving prophylactic steroids like we do in APL compared to what we do in IDH inhibitors where we don't give prophylactic steroids? So that's something that I think is something that is important. So differentiation syndrome, which can be really bad, some myelosuppression. With revumenib, two other issues are revumenib can cause QT prolongation. When you give patients revumenib, you got to be sure the electrolytes are okay. Potassium greater than 4, magnesium greater than 2. Be sure they don't have QT prolongation at the time of starting the drug. And then the second thing is revumenib has a CYP3A4 liability, so the dose is different. The dose of revumenib is different if the patient is on a strong CYP3A4 inhibitor like posaconazole or voriconazole compared to if they're on a moderate or no CYP3A4 inhibitor.
I think the entire clinical trial with the updated data, there's about 91% grade 3 or higher treatment emergent adverse events in this patient population. Now, how do you compare this with like a salvage chemotherapy in a similar patients?
Oh, it's much better than salvage chemotherapy. I mean, anything's better than salvage chemotherapy. Most of the treatment emergent adverse events are related to the disease and not related to the treatment.
Yeah.
Right. So, I don't have it in front of me, but, the most common are going to be like fevers and neutropenia and infections. Those are mostly related to the disease itself. It does take time for a menin inhibitor to kick in. It takes about a month for it to kick in. You can see a rise in blast before you see a decrease in blast. So there are a lot of things that can happen, but you don't get the gut toxicity that you would get with salvage chemotherapy. You don't lose your hair. You don't feel terrible. You feel pretty much fine. So it's definitely better than salvage chemotherapy. It's hard to have something worse than salvage chemotherapy, right? So, and if we did, we wouldn't give it to people.
You mentioned about differentiation syndrome, which was reported in about 15% in this Augment 101 clinical trial. Maybe can you contextualize this in comparing to other differentiation inhibitors like for APL treatment as well as IDH inhibitors? Because for APL, we see differentiation syndrome only in the first 30 days while they're in the hospital during induction chemotherapy, and we don't see it afterwards. Whereas IDH can happen at any time. Is
Yeah.
this similar situation with menin inhibitors?
That's a really good question. So I think we see less and less differentiation syndrome with acute promyelocytic leukemia because I think a lot of us have adopted, giving steroid prophylaxis for the first, different people do different things. I think here we do like the first 15 days or something like that. I think with, like you said, with IDH inhibitors, they can really, the differentiation syndrome can occur at any time. And that's partially because the drug takes effect and differentiation occurs at different times with IDH inhibitors. With menin inhibitors, it tends to occur relatively quickly because the response is relatively quick. I think the median time to response was around a month or something like that. So, I would say within the first couple of months is when you would normally see differentiation syndrome with a menin inhibitor. And I think it doesn't occur very, very late. Is it possible that there are some outliers? Yeah, but I think it occurs relatively early.
I presume this is a given, but if they're differentiating, are they definitely responding?
That is a good question. So it is not a given. So just because someone has differentiation syndrome doesn't mean that they are necessarily going to respond. So with APL, everyone responds, right? Like everyone is cured, essentially. It was a similar thing with IDH inhibitors in that the rate of differentiation syndrome didn't actually seem to differ between patients who got IDH inhibitors who responded versus those who didn't respond. And I don't have the numbers available for menin inhibitors, but there are certainly some patients who don't respond who still have differentiation syndrome. Now, why that is, I don't have a great answer, but I think it does happen.
Got it. Now shifting gears and talking about the NPM1 mutated AML data, which was recently published in Blood, and this year, which showed 84 patients with heavily treated NPM1 mutated AML. And in this cohort, the median age was 69 compared to Augment 101, where we came to a data where we see the median age being 35, so much younger. These patients received multiple prior lines of therapy, with 60% receiving venetoclax. Maybe if you can briefly talk about the efficacy results in this cohort of patients.
Yeah, so the efficacy results are, I think, similar to what we see with KMT2A. The overall response rate is a little, so just to be clear, like it's very hard to compare, different arms when it's not statistically, you're not supposed to do that. But having said that, we all do it. So, the overall response rate is a little bit lower. I think it's around 50%. The rate of CR and CRh is about the same, 23, 26. It depends on, again, the data cut you're looking at. Overall, I would say the results are promising. I think where you're going to get the most bang for your buck, though, honestly, for NPM1 mutant disease is in two places. One is combining menin inhibitors with other targeted agents. So, everyone knows that NPM1 mutations co-occur with both FLT3 and IDH mutations. I mean, NPM1, FLT3, NPM1, IDH. Sometimes you have all three together. So combining, a menin inhibitor with a FLT3 inhibitor might be a really interesting thing to do. There's a trial going on. There are two trials going on that I'm aware of. One is with the current drug ziftomenib in combination with gilteritinib. There's actually a trial of revumenib in combination with gilteritinib, I believe.
Exactly.
So I think that's a strategy that needs to be employed. And then, because a lot of these relapsed and refractory, a lot of the NPM1 mutant, a proportion of the NPM1 mutant patients are cured up front, right? So who relapses, right? A lot of those relapses are the FLT3 co-mutant patients. So you got to do something about that FLT3 mutation. So I think these combination strategies are where things need to go.
Yeah, one thing in that Blood paper I noticed that, especially if you look at the subgroup analysis, especially the IDH1 and IDH2 mutant patients had a superior response, about 75 versus 17 in the IDH1 wild type. IDH2 mutant had a 50% response rate compared to IDH2 wild type, which was 22.5%. Do you think there's a biological rationale behind why IDH mutant patients had a superior response in this NPM1 cohort? Or they are going to respond to any treatment irrespective? Because we have seen a similar pattern even with venetoclax as well.
Right. That they just behave well. I can't think of a biological rationale. I don't know if you have a biological rationale. I can't think of one off the top. I mean, I don't have a good answer, but it is notable, right? I mean, and like you said, like IDH patients do seem to just kind of like respond well to a lot of things, but there's got to be some biology behind that. And I think understanding that is academically interesting and may have therapeutic implications.
All right, so now let's review the Comet 001 data for ziftomenib in NPM1 mutated AML. So how do you think the efficacy results of ziftomenib compares to that, with Augment 101 that we discussed just now?
Well, I'm not going to compare it because then no one's going to invite me to do their advisory boards anymore. So, but in no, in reality, it's very hard to compare across trials. I think one thing that's interesting is that, for ziftomenib, Kura Oncology decided early on in the trial that maybe they weren't seeing responses in KMT2A rearranged leukemias that were quite as profound as they were seeing in NPM1 mutant leukemias. I've heard some theories, but I've never really understood why their menin inhibitor would work better for an NPM1 mutant patient than for a KMT2A rearranged patient. There's some folks I've talked to who have a hypothesis, although it's just a hypothesis. I don't think they've proved it at all. So therefore I'm not going to tell you what it is. But I think that, in terms of the responses, I mean, numerically, the responses seem to be similar. It's hard to say that one is better than the other in terms of primary efficacy. There may be a drug that's more advantageous in terms of side effect profile, like QT prolongation and the CYP issue. So I believe that Kura has filed with the FDA a new drug application for ziftomenib. I think Syndax also may have filed a supplemental NDA application also for NPM1. It'll be interesting to see what the FDA does and how the FDA views NPM1 mutant leukemia. Like, do they still view it as favorable risk, or do they look at the retrospective studies that suggest that once it's relapsed, it's no longer favorable risk?
So without wanting to harp too much about comparing the different menin inhibitors, I do think it is important that we highlight any different safety signals or adverse events that you would think about if you were using, other than the ones we've already talked about. So could you talk a little bit about any differences in the safety profiles between the drugs?
Yeah, so I think the major difference is the QT issue. So I think the QT issue is less or maybe not an issue at all with ziftomenib, while it really is an issue with revumenib. And the issue with revumenib isn't like a theoretical, hypothetical issue. It's like you really need to watch those electrolytes closely to be sure that because patients who have like a potassium of 2.6 and a magnesium of 1.2, and already have a little bit of baseline QT prolongation, if you give them a drug like revumenib, they actually are at risk of developing torsades and ventricular fibrillation. It's less of an issue with ziftomenib, so I think that is a significant difference in the profile. In terms of sort of drug-drug interactions, again, I don't think ziftomenib has a CYP3A4 liability. I think that's more easy to deal with than the QT issue. One thing which I was meaning to look at, because I just had a patient on ziftomenib who actually developed a pretty bad rash, and then I re-challenged him and he got a rash again. And I don't know exactly what the incidence of rash is on ziftomenib, but I didn't see that on any of the other menin inhibitors. That may be something to look at. I don't know why that would be. I don't know how the chemical is, it's immunogenic in some way. But I think those are the major differences.
So now let's move on to the combination strategies with menin inhibitors. So the combination data represents some of the most exciting development in this field. As you know, let's start with the SAFE trial, which combined revumenib with decitabine and cedazuridine and venetoclax. Can you walk us through the results, and what's your interpretation of the 100% response rate that was seen in the KMT2A rearranged subgroup? Acknowledging sample size was fairly small; it was only 7 patients. But still, 100% is very impressive. So what is your take on that?
Yeah, so just, this is a trial that was sort of put together by Gus Issa at MD Anderson. I mean, he really deserves a lot of credit for getting this trial up and running, before anyone else had a combination trial up and running. It's unbelievable what he's done down there and what that group is able to do. I mean, certainly the combination of a hypomethylating agent, in this case, the oral hypomethylating agent decitabine with that other name I can't pronounce, and venetoclax and revumenib has been quite exciting. Like you said, I think the response rates are quite high in the KMT2A rearranged population. I think the subsets are going to be important though. Like it's not just response, it's also duration of response and survival. So in patients who've previously been exposed to a menin inhibitor, is adding on hypomethylating agent and venetoclax going to be successful? If you were previously exposed to venetoclax, is just tacking on, how much more successful is tacking on a menin inhibitor, or is the most bang when you haven't been exposed to any of those drugs, hadn't had the chance to develop resistance, and then you glom them all together. I think what Gus's trial teaches us is that you can do this relatively safely. But I think even Gus would say, not to speak for him, but I will, that really what you want to do is try to do this triplet in the upfront setting. You don't want to wait for someone to relapse and then give them, decitabine, ven, revumenib. You want to give them a triplet up front with the idea. I mean, you want to do that and you want to investigate that trial up front to prevent the relapse from happening in the first place.
Yeah, that's a very, very good point. And along the same lines, even ziftomenib is being studied with 7+3 in Comet 007, where we've seen Dr. Amer Zedan from AL presented the preliminary results at ASH 2024, and updated results are being presented by Dr. Harry Erba at EHA 2025, where we have seen like 100% responses in NPM1 cohort, as well as like around probably 84% in KMT2A rearrangement subset. So those, I think, results show that I think these inhibitors, yes, they worked in the relapse refractory setting with a good response, but they probably need to be more to the frontline setting where they probably have a robust activity.
Totally agree. Totally agree. It'll be interesting to see what happens, right? Because, for at least NPM1 mutant patients, those patients tend to have a pretty high response rate to begin with. So I think it's going to be harder to show a benefit without a time to event endpoint, like event-free or overall survival with NPM1. I think with KMT2A, it'll be a little bit easier because I think the response rates, they're actually not super low. I think they're in the range of 50 to, in that Lars Bollinger paper, I think they were 50 to 60% overall, maybe 60%. So, you actually can get a delta there in response rate, right? If you go to 60 to 80, that would actually be, I think, somewhat impressive.
Given these exciting results about both revumenib and ziftomenib, there are so many other menin inhibitors that are emerging right now. We have seen so many data presented at ASH 2024. But one question I want to ask about bleximenib, which is the J&J menin inhibitor, which was striking to the most is the zero differentiation syndrome in that clinical trial, which we thought it was a side effect as an entire class, but there was no differentiation syndrome with that menin inhibitor. Why do you think that is?
As a single agent?
Yes.
Yeah, I don't believe that.
Okay.
I
Probably.
think that, I mean, not that I think anybody, I mean, just to be clear, I don't think anyone's lying, but I think that it's easy to call differentiation syndrome something else, right? You code it as pleural effusions or pulmonary edema, or I don't know, lower extremity.
Pneumonia even, yeah.
Was that?
Pneumonia even. I mean,
Yeah,
we
exactly.
have
Pneumonia.
with CAR-T toxicities, it depends. You can call CRS sepsis or you can call CRS CRS. It's the similar.
Exactly. And like all these drugs work by causing myeloid differentiation. So when you any drug that causes myeloid differentiation in AML causes differentiation syndrome to a more or less extent. So why would this drug be different than all other drugs?
So one thing we've seen in these trials reported as MRD negativity, and in Augment 101 also we have seen MRD negativity. How do you define MRD in KMT2A rearranged AML? Is it based on FISH or
well,
is it
here
based
I'm going to get myself in trouble. I wouldn't believe the MRD data in the following way. So, and for the reason you just said. So the MRD data that was at least in, I mean, let me just qualify that. It's not that I don't believe it. It's so that it's left up to the discretion of the investigator how MRD was defined. So some people said, well, they're FISH negative, so they're MRD negative. Some people said they're molecularly negative by NGS for NPM1, so they're MRD negative, but they didn't use a high sensitivity assay. I think the biggest issue is that, at least in our hands, monocytic leukemias, it's very hard to define MRD by flow in a monocytic leukemia. So something that might be called MRD negative, there might still be some abnormal monocytes there. So I think the true rate of MRD negativity needs to, at least in NPM1, needs to wait for a trial that really does RT-PCR for NPM1. And then I think there's a group that's developing a MRD assay for KMT2A. That'll be interesting to look at also.
With revumenib FDA approved, as well as ziftomenib probably will be FDA approved very soon. I think the biggest elephant in the room is resistance. Your group led the paper in Nature back in 2023 showing that 38% of patients receiving revumenib in Augment 101 developed MEN1 mutations affecting the drug binding site, and there were classic canonical mutations that were reported in that manuscript. And it was detected as early as 2 months after starting treatment. So can you talk more about these resistance mutations, and are you actually checking for these mutations when you're starting to see a patient is not responding anymore, or change in blood counts, or patient developing more symptoms?
Yeah, so the way this came about, just to make a very long story short, is that we have this FDA-approved panel at MSK called the MSK Impact Panel, which looks at 515 different genes. It's a solid tumor anti-heme panel. It happens to be that multiple endocrine neoplasia, or MEN1, is on that panel because these patients get cancer, right? So it was sort of like it was a little bit serendipitous that we picked this up because we happened to have this on our panel. We send impact testing or NGS testing with every bone marrow biopsy. So we're looking for this with every bone marrow biopsy. Now, once we had seen it with the NGS, we now have developed a digital droplet PCR assay research test, not an FDA-approved test, but a research test which is much more sensitive to look for these MEN1 mutations. And then, so if we find, so we have been in patients who relapse, we do look for these MEN1 mutations by digital droplet PCR. I do want to make a point about what some other companies have said. So other companies have said, well, we don't have the same rate of resistance. It's important to note they're not using the digital droplet PCR assay. Many of the patients that we identified with these resistance mutations didn't actually clinically relapse. They were just like caught to have the mutations before relapse. So to do an apples to apples comparison, what we would need is either for other companies to do the same assay or them to send their samples to us so we could do the assay. There's a great presentation, which I don't know if you're going to get to, by Wallace Bourgeois, who's in Scott Armstrong's lab, basically modeling that with whatever menin inhibitor you give people, you're going to get mutations that lead to blocking and binding, even if they're not the exact same mutation we see with revumenib. I think the other reason we can probably infer that there are resistance mutations arising with the other menin inhibitors is because the duration of response between menin inhibitors is all about the same. It's all about 6 months, whatever menin inhibitor you give to a patient, which suggests that probably there's resistance or resistant mutation arising that is causing the relapse that just hasn't been identified yet. By the way, we are aware of, again, they're my patients, so I'm allowed to talk about them, but we are aware of patients who have received revumenib and developed a resistance mutation, which then is overcome by giving the patient bleximenib. I'm aware of one patient like that. I'm aware of a few patients who, for reasons that are unclear, I hope Johnson & Johnson downloads this because they don't know this, so is that who have previously received bleximenib, not responded to bleximenib, and then went on revumenib and responded. So it does go both ways. And that's something that needs to be sorted out, in the lab.
So just to ask you a follow-up question, and the data you presented is quite fascinating, and we probably need to have more understanding about how to sequence these agents. about the MEN1 mutation, so you're doing the entire gene, the droplet digital PCR, or only a particular
Oh, that's
canonical
a good question.
mutations?
I think it's only a particular portion of the gene.
Do you test for these mutations before starting a menin inhibitor?
Not by digital droplet PCR, but they would be picked up on our impact panel. We did do digital droplet PCR for the Nature paper on pre-treatment samples, and none of those patients were found to have. I mean, no one believes it. They're like, how could resistance arise so quickly? Because, like you said, it can rise within 2 months.
Right.
I mean, I think it speaks to how addicted and how dependent these cancers are on menin. That it's working hard to mutate to keep that drug from binding. So
yeah, that's quite fascinating. Dr. Stein, this has been an extraordinary discussion. Your insights from the early development through FDA approval as well as the real world implementations have been invaluable. To our listeners, we keep the deep dive into menin inhibitors has been informative. These agents represent a true breakthrough for patients with historically incurable leukemias, and we are just beginning to understand their potential. Thank you so much for your time.